Well, good morning, everybody, and welcome to the Health and Wellbeing Board. Before we start, I really want to record online that I'm very disappointed with the number of co-opted representatives who are failing to attend on a regular basis. We are just quorate today, and we've got important business. As I say, I'm very disappointed. We have 9 that should be here, and we've got 4 of us. So, because of course being online does not count for any votes, etc. So I think with these notes that go out from this meeting will be that we need to be mindful of what's happening and decisions that are being made with the barest number of people. It is not representative, and I'm very perturbed that this has been getting worse over the year. There are some people that we have not seen all year long. That is not satisfactory. So we will record that, please. So with that, I shall say good morning and welcome to those of you that have come to the last Health and Wellbeing Board of the municipal year. Before we start these proceedings, may I bring your attention to some housekeeping matters. There's no fire alarm due today, so therefore if the alarm sounds, please follow the fire and emergency procedures that are applicable to the council house, which is basically leave by the most safest door and convene outside by the law courts. This meeting will be broadcast live to the internet and will be capable of subsequent repeated viewing. By entering the Wolfspite room and during the course of the meeting, committee members are consenting to being filmed and to the use of those recordings for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it is switched off when you're not using it. As she quickly turns her mobile device to silent, can I remind you all to do the same? Thank you. So, moving on to item 1. Elliot, any apologies for absence?
Thank you, Chair. Apologies received today from Councillor Lang. Councillor Murphy is substituting. Apologies received from Councillor Carlisle. Apologies from Gary Woolbridge, Interim Strategic Director for People. And apologies from Matt Garrett, Service Director for Community Connections. Thank you.
So, anything from David Haley?
Not that I'm aware of, Chair.
No, right, okay. Right, declarations of interest. Do members have any declarations of interest to make in respect of today's agenda? No, right, thank you very much. Chair's urgent business. I've not been made aware of any urgent business. We have the minutes of the meeting held on the 24th of January. Are you content that they're a correct record? I think they are. Yeah. Can I have a seconder for that, please? Thanks, John. Thank you. And you all agreed. I think it's probably Tony. I think you're about the only other person that was around at the time, so you're happy with them as well. Thank you. Questions by the public. There have been no questions received for today's meeting. So that brings us on to item 6. David and Victoria, very, very welcome to you. So the floor is yours.
So good morning all. I'm here to take you through the pharmacy strategy. This is a bit of work that is aiming to develop us for the future. It's looking at how we do pharmacy recovery and how we do pharmacy development going forward. It's very much trying to look at the aspiration of where we want community pharmacy to be in the future. So today we are really talking about how that might look. We want to explain the context for what we're doing, which is to survey everybody about what their views about what survey pharmacy should look like in the future. And your input is really, really important to us in that as Health and Wellbeing Board, because clearly you are responsible for the PNA, which sets out the fabric of community pharmacy as it would look within the Plymouth footprint. So what we're going to do today is look at that national context, outline a number of community pharmacies in Devon, looking at the changes that are going on, talk a bit about the challenges that are there, think about some good news stories that are happening, because there are some good things happening as well, and using the session today to talk through those stakeholder survey questions, explore your opinions around those, and seek your feedback so that we can build those into the strategy as we go. But it's really important to say that doing that survey is really important part of the actual evidence we're going to build into that strategy. It does state on it that it closes on 29th February, but I think that's now been updated because clearly it will close after. I think it's in 2 weeks' time, Victoria. Now.
Yeah, that's right. The survey is open till the 21st of March.
21st of March. So please, if we could have your input by then, that would be really appreciated. Are we able to put the slides up? Yeah. Okay. Okay, so first slide, if I could. I think I'd largely talk through the first slide, actually. So your input into that is really, really helpful. And we're looking to actually have this strategy ready and completed by May 2024. And we will try and link into some of the PNA work as well regarding the health, Welsh and the public engagement. As we mentioned, I know you'll be involved in that, Tony. So the intent is to have the strategy and the PNA working alongside each other to some extent. The PNA hopefully reflecting what we're doing in the strategy and to enable us to move to a different future going forward, one that's far more responsive and effective and delivering to the patient need as we see it. Okay, next slide if I could. Yeah, so in terms of the national context, there is quite a lot of evidence base around what pharmacy could do and should do. So there's a fuller stock take which looked at the broader primary care arena. There's also priorities and planning guidance, etc. There are things around access and recovery plans, long-term workforce plans. All of these involve pharmacy and its context within the community environment. The one that was probably key in helping us frame this is the vision for community pharmacy. It was a King's Fund and Nuffield Trust piece of work that was done in September 23. So we've pulled quite a lot of that into some of the thinking around this work. There's also activity going on now around the Prescribing and Pathfinder programme out in September 23, which sets out how we'll move towards an independent prescribing world within the community pharmacy setting. And then there's the Royal Pharmaceutical Society work as well around workforce, because workforce is one of the key issues around developing pharmacy, particularly in the southwest. Health Watch, obviously your patient experience work, we brought into the consideration, and things such as how we might expand minor ailment services and community pharmacy framework. All of those have gone into this. And plus the important bit, which is the pharmacy school opening in Plymouth with the new intake in September 24. And that will impact on our workforce situation and a number of other areas, such as how we might attract people to the area and potentially research and other things. So it may become a far more vibrant opportunity for us going forward. Next slide, if I could. So if you wanted to look any further at any of those, there's a series of references within this packs. If you wanted to look at the detail behind any of those things, so they're just there for your reference if you need them. Next slide. So in terms of the overall picture, I did bring to you a while ago the situation in Plymouth, where we know there is a significant reduction in the number of pharmacies, but we're also seeing that reduction in the wider Devon environment. It's true to say that the retraction in Plymouth has been more profound than in wider Devon, but in the wider Devon environment as well, there are some key areas of risk that are being identified as the number of closures continues. So we have had a reduction in numbers of pharmacies and a reduction in number of particularly long opening pharmacies. Where we have those 100 hours pharmacies, etc., they're often reducing their hours, or virtually exclusively reducing their hours, actually. And we're also seeing a slight change in the makeup of multiples and independents. So historically, there were the great proportion, over 60% were multiples. Now we're down to less than 50% multiples, or will be, well, actually are now down to less than 50% multiples. So we're seeing a change in the mix, a change in the hours, and a reduction in the overall nature of the pharmacy estate. Okay. So in terms of the challenges, there are a number of them. I think we've talked before about the financial situation. So the flat funding has caused some issue in terms of no inflationary increases. We've had a situation of clinical services being heavily dependent now on referrals. And it's more and more important, those clinical services, because they become an increasingly important part of the overall financial envelope of pharmacy. Also, we've had pharmacy becoming increasingly financially fragile, leading to rationalisation of community pharmacies by multiples, etc. The workforce, we've had pharmacists and pharmacy technicians have moved to some extent from community pharmacy to primary care. And we've got a higher vacancy rates in community pharmacy and low undergraduate application rates. We're hoping that situation is impacted by the opening of the new pharmacy school. So that hopefully will change that narrative going forward. In terms of access, workforce shortages and things have resulted in some reduction in those closures, and we've had some financial pressures as well in terms of driving that increased numbers of permanent closures. So access has reduced without doubt over the past couple of years. Digital, but there is significant work going on around digital, trying to increase the level of integration with practices in particular. There is more to be done there without doubt, and that would really help our efficiency and effectiveness. But in terms of all those changes, it's important to recognise that although pharmacy is pressured to provide those services, there are some really, really positive things going on out there, and actually playing into that narrative too far is particularly unhelpful, because actually it reduces our scope and reduces our view of what can be done for the future. And really we've got to go in with a positive mindset about what is doable here and build towards that positive future. Okay, next slide. And there have been some really, really positive stories. The hypertension case finding service, where we've got that integrated in particular, is proving to be a great benefit to patients. Numbers in some areas are really positive around those, and we do have ambulatory hypertension kits in a number of pharmacies that can do that diagnosis. So that's a really positive thing, and clearly hypertension is a major issue for our society. It's one of the major things that we could tackle in terms of preventable disease. Devon and Cornwall Discharge Medicines Service Network as well. That includes acute, community and mental health, sharing best practice around that. So there's some really positive things going on around discharge medicines that is impacting our readmission rates and potential lengths of stay in hospital. And pockets of integration as well. So we know things like the pharmacy consultation service in some locations where it's working together with protocols. We're getting some really high levels of interaction now. And since the introduction of the Pharmacy First service a few weeks ago, there are really significant numbers of people now going to the pharmacy, which should be having an impact on general practice in terms of their acute take. So that's a really positive step. And we've introduced community pharmacy primary care leads into the network, so the discussions and relationships with general practice are beginning to improve. And also on top of that, we've got the independent prescribing Pathfinder programme. We've got 8 community pharmacies in Devon that will take part in that, where we'll be testing out the utilisation of prescribers in the community pharmacy setting. There are some IT issues with that at the moment, so that's a bit delayed, but we're seeking to have that in place as soon as we can. It was supposed to be September 23, but it's been delayed as a result of technical issues. Okay. So there's loads of opportunities to work differently, really. With better digital integration, that's on its way. And we think actually by linking effectively with general practice, the ability to refer and to act as spokes for the general practice around service provision will be great, and there could be a real positive win for both practices and community pharmacy through this. And the community pharmacy is the strategy is trying to build on those local examples of integrated working, and that King's Fund and Nuffield vision we talked about. The rest of the session from here on in, I want to talk through about the questions that we're going to be asking you as a Health and Wellbeing Board about that strategy. And I'd welcome your input as we go. So by all means, you know, if there's questions as we go through the questions that are within the survey, please feel free to ask as we move through. Okay, so in terms of question 3, what we're asking you here is, do you agree with the 4 key things, 4 key principles we've set out about what we want the role of community pharmacy to be? So the 4 that we've set out are, we believe community pharmacy within Devon and in Plymouth should be about preventing ill health and supporting wellbeing. So supporting people in their communities to stay healthy and well. Particular focus within that about reducing health inequalities. And I'd like to remind us here that actually pharmacy is one of the few places in terms of access that operates opposite to the inverse care law. So we have more premises and activities where there's inequalities than not. So it should be a real opportunity to focus on inequalities through the pharmacy network. So we believe that should be one of the principles. The second principle is providing clinical care for patients. So as we move to a much more clinically focused role, members of the public should be able to consistently access care from community pharmacy for common conditions in a way that suits them and supports their health and wellbeing need. And we would hope also that would reflect around the area of inequality as well in terms of providing that access. So we feel that's really, really important. So that's the urgent care aspect in particular of the community pharmacy work, but also there's some preventative aspects within that clinical care. Living well with medicines, so we believe we've got a key role around supporting people to access their medicines and to make sure they understand those medicines effectively to improve their outcomes and improve safety and ensure we deliver better value. So a key role around educating the public, supporting public with their medicines as far as possible. And the last one, an integrated primary care offer with neighbourhoods. So integral part of that primary care offer, working closely with general practice, allowing people to access care in the neighbourhoods, supporting patients, their ongoing care needs, etc. So that's the 4 principles we've set out. I don't know if there's any questions about that.
Oh.
Thanks, David. That last point about integrating into local neighbourhoods, I just wonder if we should be more explicit about identifying the opportunities in Plymouth to work in a far more integrated way with the wellbeing hubs. Yeah. And the work I was leading on last year, the NHS 100-day challenge around people with long-term conditions. We were looking at the relationship between primary care, between GP surgeries and outpatients departments, working with the Live Well long-term conditions team. And our focus in the voluntary sector is much more about those wider social determinants, yeah, and what I would call lifestyle medicine, which are all the behavioural changes we want people to adopt alongside any medication to reduce the requirement for medication. There's something there where I think we need to triangulate primary care networks with pharmacy and wellbeing hubs in the community. Yeah. And something I can certainly take back to the wellbeing hub and that ongoing work about people with long-term conditions. Yeah.
There needs to be some synergy between the approaches. Yeah, that's a very valid point. Yeah, yeah, we'll see if we can add some text in there that reflects that.
Yeah.
Okay.
I think it also comes down to the fact that there are fewer pharmacies within communities, as some of them are closing, that some of this becomes more difficult. So how else can we manage to find another building, for instance? I mean, if you think, my own ward of Sutton and Mount Gold, we've got 2 of the Boots pharmacies in that area gone. So you're talking about, a fair distance for some people to go. So how they're not going to be able to get some of this support information, etc., where, and I think that's becoming more and more obvious. I mean, if we think about Pauline with Efford, again, you've had pharmacies close over the year, haven't you, up at the top of Efford there? And I think all of us, I think there's no councillor probably would say that it's improved. So I think it's, how do we manage to do this when we haven't got the buildings and the staff to do it? And I think that's that balance, isn't it, to find that?
Yeah. So I think it's important to reflect that we're trying to build our vision of what it should be like here. And I would reflect as well that this is why probably we brought the PNA forward in Plymouth, because you have been more affected in other areas. We would hope to be able to reflect in the PNA a pharmacy estate that is able to deliver what we wish to do in the strategy. So if we're reflecting the strategy, we want that access, then we would hope the PNA would reflect that and be able to deliver us an estate that's able to provide what we need to do for our citizens. If that makes sense. Does that answer your question, Mary? Okay.
Yes, I think you're right, which leads us on to question 4, really, doesn't it? Because that links, doesn't it, as to what we think it should be. And I think, we're right. Is there more scope for using wellbeing hubs as well in this? I mean, you talk about that sort of system, hub and spoke system, don't you? Sort of hub and whatever it is later on, that you're saying that something could be done in one place and then taken out to another building, and that may well be where community wellbeing hubs could come in, that they could be a drop-off point or something like that, couldn't they? So I think that's something, a dialogue that we need to have. Yeah.
Okay. Next slide. So the next thing we want to ask you about is what do you think a good pharmacy should look like? So what we've done here is provided you some characteristics. That's about accessibility, the co-location, which comes back to your point, consistent service provision, efficiency of medicine supply, things such as that integrated working, the provision of that wide range of services, provide online services, about the advice, and also about the management of minor illness and long-term conditions. We'd like you to rank those in order and provide your feedback on that, and that will give us a really good viewpoint on where you believe community pharmacists should be developing themselves to provide for the public going forward. Okay. Any comments about those or any questions you'd like to ask? That will be quite an important bit of information.
Tony.
Thanks, Councillor. David, I think the one thing that's missing from what does good pharmacy look like is communication, and that communication to patients on the services offered. Now, whether that's done through the website, through actual posters at the location of the pharmacy, using local GP surgeries also to get that message across. Because I think if we don't do that good communication, the populace won't understand actually what's trying to be set up here in terms of pharmacy moving forward.
So you're talking about more than signposting there, you're talking about what we do. Yeah.
Absolutely.
Okay.
Ruth, do you want to come in?
Yes, I think it's been a really good discussion so far, and I think there's so many of the key points have already been picked up, and obviously I know that Dave, he was very obviously incredibly aware of all of these, and I think you talked about the inverse care law and all of those sorts of things already, and I really welcome the fact that that is being considered. I thought I'd put my hand up on this point in particular because I think ranking these is almost impossible, because what's the point of having a fantastic pharmacist that can give you all the drugs you need and all the advice on them if they're not accessible? So I think that there's probably a few challenges for us to just think about in terms of, how do we rank those? Because we are really concerned about inequalities. We do recognise that some of the places that community pharmacists are so valued are those places where they're closing because that population perhaps are less able to access things online, or they may be less able to travel into a larger store in the middle of the city or whatever. So, to me, I think that accessibility is incredibly important, but clearly so many of the other factors are important as well. So I think there's a big challenge there in terms of ranking them. And that sense of what are the essentials. I think we could sort of do what the essentials are, but that again it feels as if they're not accessible, then what's the point? So maybe I've answered my own question, but I just it is a real challenge, that one.
Yeah.
Thank you. John?
Thank you, Chair. I mean, I agree with Ruth. I was going to say I think ranking is difficult because they're all important. And perhaps there are some core services there that are, absolutely essential. But going back to what Ruth said about communication, I think I hear, and I know from experience, there are problems actually getting hold of pharmacy sometimes on the telephone to find out, whether the prescription's there, whether it's arrived from wherever it's coming, particularly if there's problems with delivery and supply as there are now. And I think that can cause a lot of extra work for probably the pharmacist in the end and the patient. So I think communication by phone is important, actually.
Okay.
Pauline?
Thanks, Mary. Just to follow on from what John's just said, because you can get a text to say that your prescription's ready at the pharmacy, but what they fail to tell you is actually it might not be your full prescription, so it could be only 1 or 2 items, and you might need to have 5, which means that you've got to keep going back to that pharmacy. So I think that's really important that is addressed, because that happens to me on many occasions. I go up thinking that my prescription's there. They're telling me my prescription's ready, but actually there's only 1 item and I need 5. So that's not very helpful to the to the patient.
Come back on that note. I mean, that happened to my mother 1 week. I think she had 3 different deliveries, or did I pick up one of the bits? And actually, the one that was the last to arrive was the one that was the most urgent. The others weren't that important. So this is all to do with supply issues as well, isn't it? But it creates work if people are having to go several times, or the pharmacy is delivering it. I think it was 3 times in a week.
Yeah. Yeah. Thank you. Okay. Next slide. The following really we provide by all community pharmacies, so dispensing prescriptions, disposal of unwanted medicines, providing public health advice, reconciling medicines, signposting patients, and patients that look after themselves and take care of. But we want to really talk about what additional services to that you have. So next slide, please. So we want you to think about what your next top 5 would be. And they might be a range of things. So it might be about advising on new medicines. It might be about contraceptive services that are just coming on stream, hepatitis, independent prescribing, which is now beginning to emerge, managing minor ailments, managing acute common conditions, blood pressure monitoring, long-term conditions, near patient testing such as strep A, reviewing use of appliances such as thermal products, etc., smoking cessation, flu and COVID, travel vaccinations, weight management services. Now, a number of those are in place in a number of pharmacies in the city, but they are all optional ones. So none of the things on that list are compulsory to pharmacies, but you will see, for example, for the hypertension monitoring, that will be in quite a number of the pharmacies. But we want you to think about what are the real things that you want to make sure that you can get high access to across our city. So just thinking through that list, just like to give us your view about what the most important ones to you are. Okay, any questions on that one?
Rob?
Yeah. I'm just marvelling at this super pharmacy and everything they're going to be able to do. But I'm looking at that list and they're thinking, yeah, that would really work. That'd be fantastic. But a lot of those services could be available in the wider community as well. I don't know whether it would be instead of or as well of. obviously one track mind thinking about wellbeing hubs, vaccination services we've run from the hubs. You could easily run the weight management, smoking cessation there. I think you could do a lot of work around hypertension, different ways of doing that. So rather than just putting all of these requirements on pharmacies and the difficulties that some will have, particularly with the sites and and physical locations of them, it's about sharing that load across the wider community, isn't
absolutely.
it?
I'm not suggesting otherwise.
Yeah.
It's a question that certainly some things we would want to make pervasive across our communities to make sure that we maximise the impact on the population. Particularly things like hypertension monitoring and vaccinations, things such as that. So we're not detracting from that whatsoever by doing this. This is about, do we believe that it's really important to make them available widely within a community pharmacy setting?
Ruth, you want to come in?
Oh, thanks. It's just for clarity, and I think I know what you're going to say. The first point, you mean this is about talking about the medicines that have been newly prescribed for the patient, aren't they? Not about new to the market or alternatives or something like that. Medicines that it is specifically, about that. And I think that is, that's really fundamentally important, particularly around, we know that a lot of people find starting a new medication particularly can be quite challenging. I don't know if you read the leaflets that often do come with them, and whilst there's some important information in there, there's an awful lot of information that's quite difficult to follow, to understand, etc., etc. And I think actually that role of the pharmacist on helping to increase the likelihood of adherence to the medications is really, really important, isn't it? I just wanted to clarify. Thank you.
Anybody else want to come in on that? No? Okay, thank you.
And so I'm going to move on to talk about sustainable models. So it's a question of where you see a sustainable models of community pharmacy looking like. Now, there are various ways that we think we're going to need to change what we're doing. Sorry, next slide, apologies. Change what we're doing in order to become more financially and viable and effective within the communities. So thinking about the clinical check by pharmacists, we're thinking about, that perhaps that should be by a pharmacist, and the dispensing being done by accredited accuracy checking techs, who are now often registered as well, supported by technology, scanners, robotics, etc. That's basically to increase the efficiency of the supply process and freeing up pharmacist resource for services delivery. Repeat dispensing done in central hubs, that's already beginning to happen to some extent, distributed local pharmacies for collection. Fewer larger pharmacies, potentially with more than one pharmacist to drive clinical services. Obviously, there's a trade-off there with access, but that's about increasing capacity to offer training and development for other placements as well. Integrating certain elements of GP clinical systems, so improve efficiency in that way. Increasing electronic repeat dispensing to basically drive economies of scale and forward planning, and to utilise local pharmaceutical services contract opportunities. This is a different contract to the standard community pharmacy contract. It becomes more services-led, but it's a specific contract between a particular pharmacy and the system. It is potentially more expensive, but it gives you more flexibility and increases resilience potentially to that pharmacy remaining in place. So they're the potential things that might be looked at. Some of them will be looked at in terms of driving efficiency by the pharmacies. But we just wanted your perspective on those in terms of where you felt sustainability moving forward.
Pauline, do you want to come in?
Yeah, thanks, Mary. I just want to touch on where you've got about the hubs.
Yeah.
Because with all due respect, I don't even think the hubs work now. This is personal. When I go and get my prescription and I haven't got all my prescription there, I get told by the pharmacy that I'm going to, the hub stopped it. I don't know why the hub stopped it, and so then they have to put it back on the system. So I don't know what the hub does, but they actually stop medication, and that's quite worrying, because I don't know who they are that are stopping the
Right,
medication.
I think that's worth a discussion offline.
Absolutely,
Okay,
I'm quite happy to do that.
I'm happy to feed that back.
And that's not, and that's happened on many, many occasions, and that's why
Okay.
when I go, and I'm not the only person, because I see it all the time when I go to the pharmacy, that you haven't got a full prescription.
Okay, we need to understand that. It might be, as John mentioned earlier, about supply stock issues, which are. It may be.
No, it's not.
Okay, if it's not, then let's.
No, it's not about stock
okay.
issues. It's about the hub saying
Okay.
they've taken that off, and I'm saying, so why? Well, we don't know. They've just said it's they've taken you off it.
I think that might be two different hubs, if you see what I mean. I think it's what is the hub? I mean, in what I view it as is the surgery that I go to has a central pharmacy arm, shall we say, and sometimes they will say, oh, you need a clinician's say so for this drug that you've been on for years and years and years and whatever, and so you can't get that prescription. So I don't know if sometimes some of these words get mixed up. I mean, are you saying a hub and spoke model is more like there is, let's say, Boots would then send it off to a branch here, there, and everywhere, rather than the surgery being the hub, if you see what I mean?
Yeah, you're very right to pick that up. There are various terms of hub. There is a basically supply hub, which the multiples often use in terms of having a centralised dispensing function that gets distributed out to the pharmacies. But there's also the prescribing hub, which is run by the practices where the pharmacists sit. And you're right, they may on occasion, if it's appropriate, be doing some medicines checks, etc., which they may require a patient intervention before the medicine's issued. So that might be it. But I think it's worth just taking it offline and talking it through.
Yeah, it's not the doctor's hub, it's the supplier's hub, and I know that for a fact because the pharmacy now have taken me off the hub, and since then I've not had a problem.
Okay.
So it is the
That's
supplying hub, not the prescription.
Okay.
Thank you, Chair. I mean, Dave, I can see the use of dispensing hubs for perhaps dispensing to care homes. I think that's gone on for a while, where there's a large number of patients and it needs to be well organised on a monthly basis or whatever. But I think actually removing it from the local pharmacy to a dispensing hub is probably not a good move. And particularly now we're seeing a shift to more independent pharmacies. They're not going to do that. It's only going to be the multiples that were able to do it. So I think.
Well, this is what we want your input into, John. I think the multiples do it for good reason from their efficiency and effective perspective. It's about ensuring that's still responsive to the public. That's a critical part when you do that. And clearly there's been an issue in this case. But so it is a way of potentially improving efficiency and effectiveness of delivering supply. But clearly, this is why we want your input as to whether you feel that's one of the areas of sustainability. Do you want to just click on a slide?
Maybe it might be useful for patients who are housebound who have home deliveries. Then it perhaps doesn't matter where it's being done. So if the multiples want to do it in a hub, a bit like care homes, on a repeating basis, that's fine. But for the average person who pops in with a prescription, or maybe it's sent electronically, it's probably not appropriate that it's all done in hubs.
I think the communication bit earlier on is the key element to this, to be honest with you. If you can get the communication to the patient about what's available when right, then actually that might resolve a lot of the issues that are being mentioned here. But I think your comments on communication are important.
I think, although it's very vague about it, I think this is where also hospital outpatients linking into this whole system is got to be essential. I'm having quite a few concerns raised with me about the new positioning of the new pharmacy in Derriford, and people with disabilities, etc. And it'll be interesting to hear how they are going to manage to make sure that people can access, if it's tipping down with rain and you've got to be wheeled up that hill by a relative or whatever, you know, they're not going to stop, are they, for the drugs? So I think that's a different matter. But to me, from the hospital's point of view, and I know there's logical reasons for this, but actually being given a written prescription to be able to take to a pharmacy of your choice, if it's not a really awkward and difficult drug, I still don't quite see why that is, and that will be something that obviously the disability group can challenge the pharmacist, the hospital pharmacist that's coming to see them on that. But I do think sometimes we have to think about, it isn't just hospital care, it's how we integrate into the community as well, isn't it? And how we make that change, because certainly we know that there are patients that won't pick those prescriptions up.
Yes.
Because they've been a couple of times, they haven't got all they needed, they don't go back, and that might be that most important one that they don't go back for, and that's what's frightening to me.
Yeah.
So I think it's not going to be easy, but again, I think that's perhaps where the council can help as well with thinking about wellbeing hubs. Does it have to be a pharmacy that these things go to, or can it be other community points, which are slowly but surely building up, aren't they? And that's obviously something that can come into the mix, can't it, David?
And there are ways of doing things. I know there are some pharmacies that have collection points automated collection points outside their pharmacies now, and things such as that. So there are other things that can come into these discussions as we go forward. And there are some other bits up here that we want you to consider as part of this. So things such as, you know, do you want walk-in service management for minor ailments? There's an HS model, employed model as well, similar to a primary care network with additional roles reimbursement. So do we want something like that that practices have in terms of supporting workforce needs? Something about meaningful integrated working with fellow healthcare professionals as well. That could be really, really important going forward. So, yeah, having really true integrated working between practices and pharmacies, and potentially learning organisations and driving research, etc. So that could be a really vibrant future, potentially, if we went in that direction. So those are the type of things we want you to think about, and to just feedback to us about what you feel important out of those in terms of sustainability. And, you know, going forward from that, you know, we'd like to expand further on that. Are there any other things you might want to talk about? And you by all means, would want to bring the wellbeing hubs into that narrative. Okay.
Yeah, no, absolutely. I'm thinking, the community builders, the wellbeing hub advisors. We've got a lot of roles that would look very similar to the potential roles you'd have if you were going through that RS scheme. So yeah, it'd be great to have that.
Thinking about how we would integrate the whole is actually something we'd really like your input into that.
Yeah, I'll make sure we take it back and come back to you.
Thank you, Chair. I mean, I think, Dave, there's a problem here with the standard and size of some pharmacies.
Yeah.
In general practice, lots of general GP surgeons have big rebuilds, but they seem to be less busy now because of all the remote working. But some of the smaller pharmacies, or a lot of them, are quite small. And to be offering these different services, I mean, they may have one clinical room, that's all, and it's usually a very small room. You know, I think it's great, but actually we can't utilise pharmacy fully, or pharmacy services, unless some of them have better premises, and that's going to be difficult because, you know, they're in sort of little shopping centres, unless they can take over the next door building, and where's the finance going to come from? So I think actually the estate issues are a problem for pharmacy. They used to be for general practice, less so now, I think. But what's your view on that?
I think as the model changes, you will see as pharmacies migrate, because there is churn going on in terms of pharmacy estate moves, etc. It's not rapid, but it does happen. And as you see estate moves, you will see actually, I think, pharmacists adapting to the new environment that they're in, which is a higher service preponderance. We're seeing when new pharmacies open now that a number of them are open with 2 consulting rooms rather than 1. It's not going to happen overnight, John, but actually it's about setting a direction for where we want to go. setting that quite clearly for people so that they can make effective decisions and invest appropriately. And that's the purpose here really, is to give people a clear intention about where we want to take the pharmacy, community pharmacy, and to give people then the opportunity to prepare for the future. If that makes sense. Okay. So next is quite quick questions really. So does the current community pharmacy contract service provision deliver what patients in Devon health services need? So if you have a view about the contract and the type of service provision, you feel it needs to be different or more of the same, then please let us know that and give us some more detail about that, if you would. Okay.
Chris, I'm going to drag you into the conversation at the moment, sort of with your ICB hat on. Do you think there's dialogues that the ICB and the hospital, etc., can have to see if there's an easier pathway for outpatients, etc., from the hospital linking in with their community pharmacy? Because I mean, one of the problems with getting somebody out of the hospital, in fact, is often they're waiting for their pharmacy. So, you know, I think if we're having that general conversation about how do we improve that throughput of people that are ready to go home, whether or not that can come in as well with that pharmacy as well.
Yeah, so very happy to pick that up. I mean, Victoria's on the line, but we can pick that up from an ICB perspective if there's more that can be done, recognising that. I do know sometimes they're quite a bit more dynamic where there's particular pressures in the system, that some things like that can be supported, but we can pick that up and explore that further. Happy to take that on.
Thank you very much indeed. David?
And by all means, that's the type of thing you might want to reflect under the contractual discussion. Okay, next slide. So we talked a bit about barriers, so this is the opportunity to discuss those. So we know that there are some issues around funding, workforce and capacity, and it's just a question of understanding where you feel these barriers are really impacting at the moment. So whether you think it's contractual funding structure, whether you believe it's the rents of premises don't reflect the current funding, because we know that some closures may have been impacted by that, but you think it's pressure of workload on remaining pharmacies resulting from community pharmacy closures, because again, obviously there's overspill of that activity that can impact on a pharmacy's ability to continue to deliver service provision. Lack of space in smaller pharmacies, as you mentioned, John, and their ability to accommodate that additional workload. Workforce shortages, recruitment, and things like lack of placement supervisors for trainee placements. So interesting to get your perspective. Again, we're asking you to rank about which of those you feel are potentially hampering our ability to move forward towards a vision that we are looking to deliver. And also, you know, if you think those are important things that are preventing us moving forward, if you've got any suggestions about how you overcome them, that would be really beneficial. Okay. And then there's a, if you go on, any questions on that? No? Okay, next slide, good. Then in terms of the system barriers, we just want you to think about what are the main system barriers to community pharmacy fulfilling the potential we've talked about. Is it around lack of cross-organisational communication, digital integration with GPs, stock shortages, and as mentioned, that they are hampering delivery to some degree. Mutual lack of understanding of the challenges facing community pharmacy and PCNs and ICBs and practices probably within that. And, you know, mutual lack of understanding of the potential as well. So something about challenge and something about potential in terms of do we truly understand that mutually. And increasing patient demand when there's limited workforce capacity. So again, if you can think about those and think about what bits of the system are impacting on our ability to deliver where we want to be. And again, if you can give us some views about how we might overcome those. And lastly, do you see any other barriers to getting where we need to be with community pharmacy? So if you can give us some view on that, that would be really helpful. Okay. Any questions?
Yeah.
Are there cultural issues to overcome in terms of, if we imagine, excuse my ignorance, but how many pharmacies are marketplace pharmacies, and how many are there any not-for-profit independent pharmacies?
I'm not aware of not-for-profit community pharmacies, but
So everything's got to be driven through contract specifications, I suppose.
yes,
Okay.
yes. But the contract I mentioned earlier is more a negotiated contract rather than a national one. It gives you a bit more flexibility to do those things, but it does come with an increased cost in reality because it's more service orientated.
Sorry, yeah. Well, I suppose we're wanting the pharmacies to deliver beyond the scope of a contract.
Yes.
A lot of what I'd like to see are intangibles and difficult to probably enforce in a contract, really. So I was just interested in, you know,
Yeah.
other models and other potential ways of developing pharmacies in the marketplace that might have a different ethos and values and way of working.
I mean, there have been some discussions when we did the primary care home work, etc. With the National Association of Primary Care, there were some discussions about how you would potentially bring a collective together, but they were all independent business, still working with a profit enterprise. But it was talking more about, you know, how you collectivise and work mutually for each other.
Yeah.
I agree the behaviours bit is an important discussion item at not just a community pharmacy level, but an ICB level, about how we work together in an integrated way. And, you know, there has been discussions. I know the ICPD have been turn the chair work and other things around that. But yeah, if we're really going to move forward, yes, behaviours and becoming more system orientated and more collaborative will be a primary element of that success. That's why we've introduced the primary care network leads in community pharmacy, so they can liaise directly with the senior people within the PCNs to try and build those relationships and try and get that the nature of our working together as more cohesively as possible.
I mean, it's difficult enough to get the voluntary sector to work collaboratively at times. You know, I'm not saying.
Yeah, I understand your point.
Yeah,
it's but it's not one you overcome quickly. It's a journey.
Yeah.
Okay. No question. Okay. And then we come on to talking about integration, talking about how we might work in an integrated way. So again, we want you to look at how you might rank these in terms of the importance of how we drive integration in a PCN setting, whether it's about, you know, accurate, consistent signposting, if it's about safe transfer of clinical information, about provision of accessible services, about the way we provide those services, and about the way we potentially include the community pharmacy teams into that PCN workforce planning and start to work as one team. You know, a development of address the gaps of service provision and workforce across that primary care arena as a consequence. So I want you to think about that and think about how those things are important in terms of driving integration, and then also about anything else you want to talk about which doesn't work so well about community pharmacy, if you want to put your views in there, and what else you think needs to change, really. So they're the last questions. Integration is going to be a really, really key part of us going forward. So, you know, any further comments you've got around that would be welcome as well. Okay.
Thank you. And looking to the last slide we've got, of course, it says the 29th of February, and we're now saying that's the 21st or
21st of March.
21st of March. Excellent. So I think, folks, whether you want to put something in your own independence sort of thing, but Elliot's been scribbling furiously here, so we'll see about putting something together from the Health and Wellbeing Board. Ruth will run that with you and with Rob. With that help, all right? I think it's important that we do put something forward from us, but I don't see this. Yeah, I think you ought to be putting your own in as well if you feel that way. Thank you very much, Lee. The survey that then comes next, this one yours as well, the Devon Community Pharmacy Strategy Survey, is
That
that
is-
all
that-
part
that
of,
is-
that is the,
that
that
is
one
the
that,
questionnaire.
just the questionnaire,
That is the
great
questionnaire.
stuff.
Yeah.
Excellent, that's good. I don't think we could leave pharmacy at the moment without some of the concerns. I mean, I've received a couple of pieces of casework over the weekend particularly, and I apologise, Rob, I've not sent them on to you to see how we deal with them, but people that can't get, and I would say specialist drugs at the moment that are essential, and I'm just wondering whether we ought to be developing that if you can't get it from a community pharmacy and it has originated perhaps from the hospital, whether we need to be having that dialogue so that somebody knows that they can go back to their outpatients or to the nurse that's attached to those clinics and say, I cannot get it, can you see if you can get it? And I believe the gentleman that contacted me ended up having to do that. But there are some drugs that are actually essential for their carrying on living, basically, and if they can't get them through the normal channels that they would have got because of drug shortages, it seems that we have to have, and I think this is Victoria and Chris is where we need to be, you know, sort of getting you to help make sure of that, because it must be quite frightening for somebody to find they can't get a particular drug and they know full well if they don't have it, something's going to build up in their blood or whatever that's going to cause them a cardiac arrest or something, you know, something like that. So I think we need to have that dialogue with the outpatients teams and also with the chief pharmacist at the hospital, I think, to get a pathway that's known to community pharmacists so that that sort of problem doesn't arise. Tony, I don't know if you've been coming across that through people coming up to Health Watch to say that they're having real problems with particular drugs. I mean, I know obviously from talking to Pauline, she's had particular problems, but I just wonder if it's coming a more general thing.
Yeah, I think we get information two ways. So we pick up that patient experience where scripts are not fully filled, and often it's down to a supply issue. But I guess the other information we get the regular updates from NHS Devon that go to the GPs on where there are supply issues or shortages. So I think from that perspective, it's an ongoing national thing. It's not unique to us down here, but it is frustrating. I must admit, you know, I've suffered from it myself, and you do get frustrated when your meds aren't available.
Colloquially, it was being blamed on Brexit at one time because we weren't getting the drugs from the EU and that. But I'm presuming now we're a long time past Brexit. So I just wonder, is that still affecting drug delivery, or is that something that people just now say, Brexit, blah, 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 it's caused this? I don't quite know if it's fact or fiction.
There's a multitude of factors. I mean, economics, as with all things, play a part in this in terms of the drug prices in the UK are quite tight, and therefore there may be more attractive markets elsewhere for companies to but there are a multitude of factors, and it would be wrong to just say there was one. It's, you know, it's a national issue. It isn't just a local one, and I know there is significant work being done at national level on this, but I personally don't see anything at this point in time that suggests that situation is going to immediately improve. So I can go away and seek further advice on that because my knowledge isn't huge on it. But if you'd like me to come back on that, I will do so.
Thank you, Chair. I mean, Dave, some of it is sometimes quality issues, that batteries that are produced of certain drugs aren't up to standard, or can it be ingredient supply problems? I mean, it would be interesting to know, if it was possible, what the breakdown of reasons for shortages or delays in medication supply are, if that's possible, wouldn't it?
I can attempt to get it, John, but I don't know if it's available. But I will endeavour to see what I can find.
Ruth or Chris, did you want to come in at all on this, or Rob Nelder? No, silence, great. And I think also, it's, and I'm sure this happens in pharmacies, that if a particular drug is not available, that the pharmacist discuss that with the patient, and so that they can go back to the GP and say, this, that, or the other is happening. And I think that, to me, is that it's that relationship, isn't it, between the pharmacist and somebody that goes there regularly, that gets lost when you get those community pharmacies closing. And I think that to me is something that we will lose with some of the closures that we're having at the moment.
Yeah, it isn't as always straightforward as people believe, because at the end of the day, from medication, you do not necessarily know the condition of the individual. So you can't necessarily recommend an alternative medication to the GP without having a discussion with the GP. So it does require normally some discussion between the two parties. And again, when pressure is on, those conversations are often quite difficult to occur quickly. You know, it's assumed that it's relatively easy just to switch medication, but it does require a bit more effort than that.
Right, any more for any more? No. David, thank you as usual.
Okay.
Always very useful. And Victoria, thank you as well for joining us this morning. We will definitely make sure there's something from us. And I think perhaps, Ruth, if you and I can have a quick discussion as to whether you think this ought to go out to all councillors, to give them the opportunity to fill, even if it's part of the form out. I think that might be quite useful to
Yes.
get a broader picture as to what's happening. Thanks. Thank you very much indeed, David, for your help.
Through you, Chair, I wonder if there's a recommendation there then that we delegate to the Chair yourself of the Plymouth Health and Wellbeing Board to submit the final response on behalf of the board, seeing as we haven't managed to fully complete today.
Are you all happy with that? Yep. Nobody seems to be disagreeing. Right, thank you very much indeed for that. Rob, I think there's some good suggestions that have come out from there, so I'd certainly hope that you will put something in independently. Thank you. Right, so that moves us on to the next agenda item, which is suicide prevention in Plymouth. But before we move on to that, I think what we also need to look at as well is we were going to be looking at the pharmacological needs assessment, weren't we, and how we proceed with that. So I'm just wondering, Ruth or Rob, whether you want to give an update as to how we're going to be dealing with that next.
Do you want me to do that, Ruth? Yeah. So so the pharmacy needs assessment, I think as agreed at the last Health and Wellbeing Board, we have agreed to go early with it. But based on the conversation we had at the previous Health and Wellbeing Board, we've set up a series of meetings, joint meetings with colleagues in the Devon, representatives from the Devon Public Health team. So in effect, we've set up the PNA steering group. Dave Bierman, who I can still see in the room, is a member of that, along with Sue Taylor and various others. We've got monthly meetings set up to take us right through until hopefully publication or sign off at the Health and Wellbeing Board next March. We've made contact with colleagues in NHS Devon who are going to provide some of the data to support us with that. And obviously, one of the things that we talked about at the first of those PNA steering group meetings was the pharmacy strategy that you've just had a conversation about now. And the view was that the document or the pharmacy strategy will inform the PNA and not not the other way around. So we'll make sure, obviously, that the PNA makes reference to the pharmacy strategy that's being produced, I think, for publication in May, if I've got that right. So it's all systems go, basically, Chair, I would say.
Lovely, thanks very much, Rob. That's good to know, and we will helpful that. Thanks very much, David. See you soon. All right, bye. Okay, thank you very much, team, on that. So, Kamal, welcome, and Jane, welcome to you as well. Obviously, everybody's seen the notes, etc. Can I just go back, sorry, to the recommendation is that the Health and Wellbeing Board to provide feedback for the development of the NHS Devon community pharmacy strategy through completion of the healthcare professional survey. And there's a huge list of different people, you know, whether you're an elected member or whatever, that you can tick to say that. So it isn't just healthcare professionals that need to be filling that out. Okay, sorry. So Kamal, coming back to you there. I take note with the report, and I will say it can be, if anybody is feeling that they need a couple of minutes out of the session that we are about to start, no offence will be taken if you go. I've got to say as chair that if we all, many of us disappear, we won't be quorate, so we would have to stop for a few minutes, but it could be quite harrowing for some people to read, hear and listen to some of this, so please don't feel you're letting the side down if you have to have that couple of minutes out of here. Okay, so Kamal, the floor is yours.
Thank you, Chair. Is that working okay? Yeah, brilliant. So yes, I am here to present the work that is taking place in Plymouth on suicide prevention, and to update the board on kind of the information that we have in relation to the national strategy. There's a new national strategy for suicide prevention, and then to talk through the system that we have in Plymouth that tackles this really important area of work. So I'm going to share my screen to do a presentation first, if that's okay, and then we can have a discussion afterwards. So I should be in the meeting. Yeah. Share. And I can see that sharing. Great. Well, thank you. So I'm Kamal Patel. I'm an interim consultant in public health at Plymouth City Council, and I lead for suicide prevention in Plymouth. So today I'll talk about a bit about background on suicide and suicide prevention, give an overview of the National Suicide Prevention Strategy, talk about the local data that we have and information that we have, and give an overview of the suicide prevention system, the extensive amount of work that we have across the whole system, looking at this really important area. So, as the Chair has said, it's a difficult topic, and it'll be difficult for different people at different times. And so, yeah, please do look after yourself. Take time if you need. I've also put a link to our page on mental health support there at all different levels that we provide in Plymouth. So, by means of definition, suicide is the act or instance of intentionally killing oneself. Only a coroner can determine that a death is a suicide after a coroner's inquest. When we do suicide prevention work, we do talk about data and numbers, but we're always aware that these figures relate to real people, and so we're always mindful of that. We know that every suicide is a tragic loss and has devastating and long-term impacts on family, friends, neighbours, colleagues, and whole communities. The causes of suicide are complex and individual. There's rarely a single cause. And the risk factors that we know are often reflective of wider societal inequalities, and economic factors. It has a major impact on society. It's felt at a human level, but the research shows that on average the cost to society of each death is substantial as well. It's really important to note that 70% of people who die by suicide are not known to mental health services in the year before their death, which really highlights the need for a whole population approach. Clearly, mental health services are important, but that isn't everything, and it really is about whole population approaches. And it's really important to remember suicide is preventable. But suicide prevention is broad and complex and reflects that complexity of the issue. We have to look at measures to improve the whole population and the well-being of a population, and that's through many factors, including the wider determinants of health. We have to support people who have mental health issues, and that's from more low-level mental health issues or early intervention through to someone who's approaching or in a crisis. And importantly, we have to support people who are bereaved by suicide as well. So yes, as I said, it's essential that the preventative approach addresses the complexity of the issue. It's not for one organisation to be responsible for suicide prevention, and there are no simple measures to prevent suicide. It's everyone's business. It's a whole systems approach that's needed, and we work in collaboration towards the same priorities. I just put this in because I think it's useful. This is about talking about suicide, and talking about suicide is hard, but I think it's really important to say that there's no evidence that talking about suicide can plant an idea of suicide in someone's mind. It actually does the opposite and relieves that person of an internal burden, and actually, if talked about appropriately and sensitively, is actually really helpful in many circumstances. And worry about language shouldn't stop us talking about suicide, but there are some points about language that are really important to that we try and share across the system in terms of phrases that are useful to say and phrases that are more unhelpful to say, and may increase kind of stigma and worry as well. So I think the top one being the key one that we try and share around language, that we don't talk about commit anymore, because suicide isn't a crime. It can increase stigma. We talk about someone who dies by suicide or a suicide. So the suicide prevention strategy for England. So towards the end of last year, the national team produced an updated strategy. There was a previous strategy. There's an updated one that is updated based on new data, evidence, and engagement with experts, and that includes people with personal experience. It was felt there was a need for continued national suicide prevention strategy because at the current, the suicide rate is not falling. It remains the biggest killer of people under 35 and is one of the leading causes of death in men under 50. Rates in people under 25 have been increasing, suicide rates. Self-harm rates have been increasing in children and young people. We have new evidence, as we talked about, and recent challenges as well that have added to that, in COVID and cost of living crisis being two really key ones. So this is data on death by suicide nationally for England and Wales. And so the top light blue line is males, the bottom purple line is females, and then the middle dark blue line is overall. So you can see that the pattern is the same for males and females, but the males are 3 times more likely to die by suicide than females. And you can see there was a decreasing rate nationally from kind of the 80s all the way through to about 2010, 2008, that kind of time. Since then, it's been static or gradually slow, like mildly increasing at a national level, but it's still lower than, if you look at over the last 40 years, it's, there is a downward trend there, which is positive. So the first purpose of the national strategy is to make clear that suicide prevention matters, brings everyone together around common priorities. So there are actions, and it involves the government, NHS, local government, voluntary, community and social enterprise sectors, employers, communities, individuals. The strategy involves everybody. So the priority areas for action identified at the national strategy level are improve our data and evidence, which is again an ongoing thing. Looks at making sure that we provide targeted support to priority groups who are identified as being at higher risk at a national level. Also has identified common risk factors that are linked to suicide at a population level. The strategy also looks to promote online safety and responsible media content, which we know is really, really important. Provide effective crisis support for people who reach crisis point. Look at access to means and methods of suicide and see how they can be prevented. Provide effective bereavement support to those affected by suicide, and finally to make suicide prevention everyone's business so we can maximise our collective impact. So those priority groups that the national strategy identifies have expanded. So the previous national strategy essentially identified middle-aged men as the high priority group. The new strategy also does that, but also identifies a number of additional groups that are considered priority. And it's important to say that not all of these groups are considered priority because the rate is the highest in that group. So, for example, children and young people has a relatively low rate of suicide, but there has been a trend of increase, which is why that is in the priorities. Whereas middle-aged men is where the highest rate of suicide continues to be. People who are self-harmed are more likely to die by suicide than the general population. People in contact with mental health services, people in contact with the justice system. The strategy talks about autistic people as well, and we would look at locally looking at how we might expand that to neurodiversity as well in general. But that's the terminology from the strategy here. And again, pregnant women and new mothers. Again, the rate is very low, but the impact as well that it has is very high. So hence why it's there. And then common risk factors: physical illness, financial difficulty, and economic diversity. Gambling is a newly identified risk factor based on evidence, and same with domestic abuse. Whereas the other risk factors have been known about maybe for a bit longer and had more clear evidence for. The new strategy kind of really highlights those areas. And I've just put here some examples of the actions from the national strategy. So these are the ones not really necessarily aimed at local authorities, but NHS organisations and wider systems. So, for example, looking at crisis support for mental health, including things like mental health ambulances and alternatives to the emerging department. So that's something that's looking at a national level. Looking at school curriculums and education there, training among prison staff, again, support in school, and then the legislation to tackle online content as well. So moving on to Plymouth data. So we know that on average, around 24 people die by suicide each year in Plymouth. The most recent data from national is for the period of 2020 to 2022, and these are deaths registered in that time. So the death is likely to have taken place before that because there's about a year to a year and a half time between a death and a completion of a coroner's inquest to determine that as a suicide. So that's why the most recent data is for that time period. So in Plymouth, our standardised rate of suicide was 8.5 per 100,000, compared to 10.3 for England and 11.9 for the Southwest. And show that graphically. This is Plymouth suicide rate over time from 2001 through to the most recent data point being the 2020 to 2022. So as you can see there was a period in between 2008 and 2012 where Plymouth rate was above the national average, and the red dot signifies that statistically significantly above. So so we would consider that to be a true finding in that it's unlikely to be due to confidence errors or statistical errors. But since then, actually, the rate of suicide in Plymouth has been in line with the national average, indicated by the amber dots. And the most recent figure is in line with the national average. The number is below, which is good, but not statistically significantly below. But it shows a positive trend and something we would keep an eye on and cautiously, obviously, pleased about. I think it's also important to note that the deaths that were registered in 2020 to 2022 is during the time of the pandemic, and so there was an interruption to the coronial process. Clearly, that would happen across the whole country. So the fact that our rate has gone down is still a positive thing, but it's important to note that was disrupted. So we produce an annual audit summary based on the national data. And again, this covers deaths registered in 2020 to 2022 and provides a citywide overview of the death by suicide and undetermined intent. So there were 61 deaths in this time period. The ratio of male to female deaths was in line with the national average at 3 to 1. The majority of deaths occur in people's homes, and if you look at it geographically, it affects the entire city. And the full report's in the papers for this meeting. But that's the summary of the findings. So, moving on to the local system of suicide prevention, I'm going to talk about various levels of work that we undertake to work on this as a collaborative across Plymouth and across Devon as well. So, we have a suicide prevention strategic partnership in Plymouth. I chair this group as an open group. Anyone can attend that group, and we work collectively with local agencies, organisations, statutory organisations, voluntary organisations, to identify local priorities, to develop and deliver the suicide prevention strategic action plan, and that's the plan that you have in your notes as well. So we base our local action plan on the priorities of the national strategy. But the actions are specific to Plymouth. But the categories, as it were, the action areas are based on those priorities that we talked about earlier. And so, yeah, I welcome feedback after this presentation, discussion within this meeting or outside of this meeting regarding that. So yeah, our action plan, as we discussed, we aspire to work together to make all communities in Plymouth suicide-safer communities. We want to make Plymouth a place that supports people in times of personal crisis, builds individual and community resilience to improve lives. And our ambition is to deliver a consistent downward trajectory in the suicide rate that remains below or at least in line with the England average. So the next thing I want to talk about is real-time suicide surveillance. So this is information that we get on a weekly basis from working with the police and an organisation, charity called Pete's Dragons, which provide us with information on what the police call sudden self-inflicted deaths. So as I said earlier, it can take 1 to 2 years for a coroner to determine suicide. And so it's really we need to have information on deaths that are suspected suicides earlier than that, so that we can look at the 3 things that I've talked about at the bottom there, which are provide timely support for people who are bereaved. We want to provide that as soon as possible when that's or at least provide the information to that person or people who are affected as soon as possible, so they can access that at that point, not after a year or 2. So anyone who is affected, the police, we work really closely with the suicide lead at the police, and the police officers will carry Pete's Dragons card, who are our bereavement service, specialist suicide bereavement service, and provide that to anyone affected by a suspected suicide. It also enables us to identify and respond to any potential suicide clusters in a real-time, timely fashion, and look at the method of suicide and if there's any novel or trends in methods. That, again, work can be done to look at that. So as I mentioned, Pete Dragons are our specialist suicide bereavement service. It's a complex bereavement suicide. It needs a specialist service. And people who are bereaved by suicide are more likely themselves to die by suicide. So NHS Devon commission this service, and anybody, children and adults affected by suicide, can access this for as long as they need. And this can be for a recent suicide, it can be for a historical suicide. There's no time frame on that. There's no waiting lists. Support can start within 48 hours of contact. And as I said, police officers hold that card and refer straight in when it's needed. Suicide prevention training. So, as I mentioned earlier, 70% of people who die by suicide aren't known to services, mental health services, in the year before they die, and therefore, we consider suicide prevention training as one of the best tools we have to build suicide prevention capacity in the system and the population. Those 70% of people might not come in contact with mental health services, but they'll come in contact with other services, other people all the time, and so we really focus our training on workforces who are more likely to come in contact with people from those priority groups or the people with those risk factors, so that we build that capacity in the system, and people feel more confident to support people and know how and know where they might help people access specific services if they need to. We really think it's really important, something that Plymouth have done for a while, provided free training. We can never attribute a reduction in suicide rate to something individual, but we do think that has had a part to play in that reduction that we've seen over the last 10-15 years. So I put the link to the suicide prevention training here, and we have different levels because different people have different needs. So introductory level in terms of well-being and providing support for people's well-being and improving that. And then we have the kind of intermediate level, which is more around building people's emotional resilience or community suicide awareness. And then at a really advanced level, mental health first aid and the applied suicide intervention skills training is the assist course, as it's known as, is really important. So the Plymouth suicide audit. So the data I presented earlier is a summary audit that we compile every year based on the data, but we also do a really in-depth review of coroner files of confirmed suicides. So we will go and review those files and those cases, and we will pick out really important some salient points from those deaths and feed that into the local learning and to inform our local suicide prevention activity going forward. So we are currently looking at all deaths that were registered between 2017 and 2021, and we'll produce a detailed audit report this year based on those findings that will feed into the Plymouth Suicide Prevention Strategic Partnership and the Health and Wellbeing Board as well. And finally, just say, working across Devon ICS, so we have a really strong network with suicide prevention leads in Devon, Plymouth and Torbay public health teams. Those examples of joint funding, for example, the real-time suicide surveillance analyst who's funded by the public health teams. There's an NHS Devon Suicide Prevention Oversight Group, and that brings strategic oversight to the implementation of suicide prevention across Devon, Plymouth and Torbay. And that's looking at local action plans, clinical settings, and real-time, bringing all those aspects that I talked about together. I also sit on the NHS Devon Mental Health, Learning Disabilities and Neurodiversity Provider Collaborative Board to link up the two work streams. And suicide prevention is a key part of the Devon ICS Joint Forward Plan, which you'll see later. So that's what I wanted to talk about. Very happy to have a discussion now on any of those points. On any of those points, really.
Well, thank you very much indeed. I suppose when you first told me about this, I was surprised that it took that long for the coroner to have their inquest, etc. Is there any way that we can persuade the coroner's office to speed that time, you know, because it is quite distressing, obviously, for family. Although I suppose they know what the answer is already before it actually goes to the coroner. It's that confirmation. But is there any way that the system can be, let's say, speeded up to retract that, or is this something that has to be? There are set things that have to be done, and there's no way that we could get those answers any quicker.
So I think we are at a particular point where the delay is longer than it has been historically because of COVID, and the coroner's office closed for a period of time there. So it is there is a backlog, I guess, of cases to be reviewed due to that. There are certain things like toxicology reports and getting information. It's the coroner do a really detailed inquest. They get information from services. People provide witness statements. Organisations will provide responses. Naturally, that is going to take time. So while I talk about it being a year and being a year to 18 months at the moment, ideally, I can't see it really being much below a year, to be honest. And I think the coroner and the coroner's team do work with families and are supported through that process, and are aware of what's going on and why things might take longer. So I think that's really the important thing, is that the families are aware and know what's happening, because that's it's when you don't know what's happening that's where the anxiety really comes in. So
Thanks, Kamal. John.
Thank you, Chair. Thank you for that, Kamal. I've got two questions, really, or question and a comment. Under place of death, you said that 7 people in this 3-year period died in Derriford Hospital. Was that because they were there because they'd taken an overdose, or they had tried to kill themselves and were taken there and died there? Presumably, the whole process didn't take place in Derriford Hospital. And were there any in the Glenbourne? Presumably, we're not confusing Derriford with the Glenbourne here. Just wonder whether you could give an update on that.
yeah, thank you. Good question. Yes. So we're not. So yes, essentially you're right. The event took place outside a hospital in all cases that we know about, and the person would have been transported to hospital for care, and unfortunately, died in hospital. So from this audit, we're not aware of any cases that would have happened in, where someone acted in hospital. I would say that because we haven't gone into each of those files yet, because that we haven't had those files, we wouldn't actually know for certain. But we haven't been informed of any cases in this for that suicide audit period where the act took place in hospital, and there was nothing in the Glenbourne. We haven't had a inpatient death in mental health services in Plymouth in that time either.
Thank you for that. Can I come back on that? I mean, it's brought back memories of a very fortunately small list of former patients and friends and acquaintances who have taken their lives, and sadly 2 of those I can think of did die in the old Moorhaven, but obviously we're going back quite a long while. So this is over 40 years, but a couple of them definitely happened quite out of the blue. And you said that 2/3 aren't known to mental health services in the last year, and this does happen. And, I know of a former patient and a former friend who it came out of the blue. As far as I was concerned, whether they'd actually confided in anyone else, I'm not entirely sure. And then there's another group, I can think of 2 particularly. One again was a colleague's sister, and came from Plymouth actually, and a patient who had been under care at mental health services but seemed to be improving. And in both these cases, they sort of seemed to be a lot better, as reported by relatives, and actually went around sort of seeing other relatives and friends in the days and weeks leading up to it. Now, this is the problem. There are some people who you think might attempt to take their lives, but fortunately they never do. But there are others who you think, well, I think they're out of the woods, or you have no concerns at all. and it happens. Now, you know, it could be that there might be somebody who met them an hour before who could have changed the pattern of what happened. And that's why we've all got a responsibility, I think. But, you know, we're never going to eradicate this because some are completely unexpected. And even where there's been a history of mental health issues, it's not when they seem to be, you know, at their worst. Do you have any views on how we all can perhaps pick up these sad cases which happen completely out of the blue, it would appear?
Yeah, no, I think it's really important, to say that it can often appear out of the blue, and it might be that, and that's one of the reasons why we do our detailed review of the coroner's files, and why the coroner does their inquest in the first place, is so that where that information could have been, where something could have been picked up, or where there is learning to say that this might be a risk factor, or this service had contact with them. Should we do trade? You know, it's not on an individual service, but what we want to do is make more people comfortable to talk about it, to be able to identify when someone might be approaching a crisis, and to then have the confidence to be able to talk to that person. And the more people who can do that, the more likely that person who might be approaching crisis is going to have someone to talk to, or notice that something's happening, and so it's less likely to be kind of, I guess, out of the blue, as you say. So it is. We talk about suicide being preventable, and we always consider it to be preventable, and that is right. And but it is extremely complex, and that's why that whole system that we have is around there, and that's why that's why we do what we do.
Can I come in there as well? Sorry. Hi, I'm Jo Marley. I'm one of the specialists in the public health team. So just to kind of answer that point or kind of add to that, there is some evidence that shows that, you know, people who have been going through like a mental health episode and kind of, you know, really struggling with their mental health and then kind of seem to be improving, that's not uncommon. And then because they've got a plan, so they feel, you know, that they're kind of planning, and, you know, often do go around and see family and friends and kind of but I suppose it's, you know, for like some of the training kind of makes people aware of that, and then that's an opportunity for kind of family and friends to then kind of, you know, talk to that person and ask if they've got a plan and kind of intervene at that point. I agree, it's very difficult to spot those things, or to, you know, feel confident to have those conversations as well. But so one of the things that lots of the training kind of talks about is that it is safe to talk, and one of the things that Carl did have in it, you know, talked about in his presentation, is that you don't plant the idea of suicide. Actually, you kind of interrupt the thought, and asking somebody if they have a plan is one of the things that is, you know, evidence-based, and kind of is the best thing to do if you are concerned about somebody, because, you know, those are the opportunities that we have to kind of have that discussion with them, and support them to then make a safety plan and get them to that's their plan to die is no longer kind of, you've kind of interrupted that thought process. But the kind of them improving and seeing that improvement is not, sadly, uncommon. That is something that kind of the evidence shows.
Lee, did you want to come in there?
Thank you, Mary. Can I just ask, of all the people that we've got in this report that have committed suicide, do we know if any of them are former service people?
So again, that's not captured at the national level, which this data is based on, but it is part of our detailed suicide audit. And so that is something that once we have completed that report, we'll be able to feed back on. We do know at a national level that you know, we do consider it we do want to support and make sure that we have adequate support for people who have been in services, because of, you know, the trauma involved in that, for example. But actually, at a national level, the rate of suicide in people who've been in service or veterans is lower than general population, and there is a lot of support available as well. So you'll notice in the national action plan, it doesn't talk about veterans being a priority group, but in our local action plan, we've included that because of the local context of Plymouth. But we have included that in our audit information finding. So when we're able to process that information, we'll be able to provide that for Plymouth.
Okay, thank you. I'm quite surprised about the national because, and I think that's probably because I don't think the MOD services actually recognise PTSD, and I kind of like they kind of sweep it under the table. So I'm really quite surprised at that. Okay, thank you.
I'm sure Kamal will be very happy to take that forward locally for when we're looking at the veterans particularly. I think that would be very useful. Before I bring you in, Rob, I just want to basically ask, we're talking about the different training needs, etc. I think the longer I do this job as a councillor, I realise that councillors get involved with all sorts of things. So I think it really, really would be useful to see, is there one of the levels that we can look at so that it's one of those training sessions that we do on a regular basis. But I think the most important thing is making sure that all councillors have that emergency line. And I know it's now going very rapidly to 111, isn't it? So I think it would be very useful to have that and to the guidance that can be given to somebody. But I do think if we look to the new civic year, when we may well have new councillors coming in, it may be a useful, whichever sort of a basic course to do, you know, a couple of hours for councillors, because we do get a variety of things cross our paths. So I think that might be useful, Kamal.
Yeah, no, I think that's a really great point. And you know, councillors are out in the community; they're community leaders. People come to councillors. You knock on doors, so it's really important. It's something that we can look at. We can put together a short briefing on suicide prevention, which includes information about training. You know, community suicide awareness comes to mind as the kind of intermediate level training that Live Well offer for free. And yeah, we're very happy to put together something. And as you said, the Live Well crisis line, which is 24/7 service for anybody, a person or a professional to refer into, can be accessed on so anyone can call 111 now, and you'll get through to your local mental health. So the Live Well 24/7 service, and there's also on the Live Well website a professionals referral number as well. I don't have it to hand, but it's on the Live Well website. So yeah, that's really important to know. But we can put this on a briefing report for councillors.
So Elliot, I think that's probably a recommendation here to make sure that we pull that together and that can go out to everybody. Rob?
Yeah, just picking up on the veterans point, really, it's really interesting. I'd have thought it would have been higher in the veterans hub that we run. It's certainly a topic under regular discussion. And I appreciate it's just anecdotal, but given the profile of men, middle-aged, younger men, the recent conflicts and some of the issues that we just have been reported to us, I'd have thought it would have been higher. The other group I was thinking of in particular is those involved in the criminal justice system, and if there's any information on those who are actually in custody or on community sentences. I'm thinking the likelihood as well of people having complex needs and people that are in and out of the criminal justice system. But the numbers are much lower than what I'd have anticipated. We're only talking, obviously, it's significant, but it's much lower than what I would have thought given the population of the city. But is there any information on any of those that are in custody?
So at a national level, people in contact with the criminal justice system was identified as a priority group, and that does link in with some of the other aspects you talked about, people who use substances as well, and so we're doing a lot of work to improve that. What part of the national strategy was about training for probation staff and criminal justice staff. So yes, it is an area. It's a new area of work. It's not something. It's not a priority group that we've looked up for in terms of suicide prevention. So we're developing partnerships there. We're looking at bringing people from that area into our strategic partnership so that we can link in with them. Evidence-wise, it's difficult. You get more anecdotal evidence, but there are, just from our own work and reviewing codified stuff, we have seen people who have been investigated for serious offences under investigation, die by suicide. I've seen that. I don't know about the statistical level of data at population level, but I've seen that from the work that we do ourselves. And just to pick up on your veteran point as well, maybe the fact that you talk about that people are talking about it is probably a really good thing, and I think it is. It's not anything that means that we should rest on our laurels or not consider this group, because we know, as you said, there's numerous factors there that are risk factors for suicide. So it's really important to make sure that people are supported, and also family members of veterans as well. So I think there is some evidence that dependents and male dependents of veterans are at higher risk of suicide themselves. So that's a really important point as part of this work as well.
Thank you. Anybody else? No. Kamal and Jane, can I thank you very much indeed. We have some recommendations, folks, that I need you to agree, hopefully on, that we note and accept the latest suicide audit report. Secondly, that we review feedback and comment on the Plymouth Suicide Prevention Strategy Action Plan for 2024-25. And that we delegate authority to sign off for the 2024-25 Suicide Prevention Action Plan to the Chair of the Health and Wellbeing Board following its updates after this meeting. And 4, we agree for this item on suicide prevention to be a standing Health and Wellbeing Board agenda item, so that the Suicide Audit Summary Report and Suicide Prevention Strategic Action Plan can be reviewed and agreed annually. Are you all happy with those? Yep. Thank you very much indeed. As I say, thank you both very much indeed. And let's just hope that our figures improve slowly but surely, because there is a lot of work being done in this area. And I think, we commend everybody who's taking part in that. And I think it is everybody's business. It's one of those things, isn't it? And I think we need, as I say, if we can raise awareness and make sure that the information is there, safe and solid information is there for people, then it's got to be one of those. On the Chronicle, they give a whole list, don't they, of phone numbers, etc. And I think if we can make sure that those it's included, I think it might be useful and helpful and supportive. Basically, that's what we need, isn't it? So thank you both very much indeed, and we'll let you go now.
Thank you, Chair. Thank you, everyone.
Okay, we'll now have a swap of seats and welcome John. I think we're still. Okay, you do that.
Hello.
Sorry, Ruth, do you want to come in on this to begin with, or shall I just ask John to present?
No, I think happy for John to present, and perhaps I'll come in afterwards. Thank you.
Thanks. John, thank you very much indeed for coming along and joining us. It's different seeing you on that side of the table rather than up here amongst us, so welcome. The floor is yours.
Thank you, Chair. And to people who don't know me, I'm John Taylor. I work for NHS Devon
for the medical directorate, so for the chief medical officer, Nigel Aitchison, who I think you know, who would usually come and present this today, but he's unable to attend. So the purpose of the report is to provide an update to the board and an opportunity to comment on the refreshed joint forward plan, and to make sure that it properly reflects the health and wellbeing strategy and priorities for Plymouth. Now, as the board will be aware, integrated care boards and their partners are required to publish a refreshed joint forward plan at the beginning of every financial year. The plan is intended to outline how they will exercise their functions for the next 5 years. The draft that's presented to you today in your pack is for consideration and comment before the final version is presented to the NHS Devon board for approval later in the month. It describes how the health and care sector will meet the population health needs and the objectives set out in the integrated care strategy, which you will be familiar with. Now, the plan reflects an intention to work collaboratively across Devon. However, it's important to note and acknowledge that the statutory duties remain with individual organisations. As a board, hopefully you recall that the development of the integrated care strategy and the original joint forward plan was very much informed by a lot of data and evidence on healthcare need, and also quite a lot of public feedback on healthcare services collected over the last, between 2018 and 22, so quite a number of years. The plan was also directly informed at the time by overview and scrutiny committees, by the Health and Wellbeing Board, by the voluntary sector and Health Watch representatives. In terms of what's different about the version that you've got today from the plan, the original plan last year, there are no significant material changes to the version that was published in 2023. The priorities and direction of travel remain consistent, as you'd expect, because this is a longer-term strategic plan. However, there have been some changes to the structure and how the plan is sort of presented visually in response to some of the feedback that we've received over the last 12 months. And the refreshed plan is structured around 3 themes, so healthy people, healthy, safe communities, and healthy, sustainable system. In addition to the overarching sort of visual updates and structure changes, which are fairly minor, there have been some updates to the detailed plans that sit behind some of the programmes, again in response to feedback that we've received throughout the year. And then one thing that has been added is a section describing the key achievements for 23-24. So there's a bit of a look back at what's happened over the past year. And also there's a bit in there now about the what delivery will look like for the people in Devon to bring the plan alive a little bit, again in response to some of the feedback that we received last year. So the recommendation today is to consider the plan, and on page 4 there was a comment, a statement from this board last year. So if you wanted to update that, that would be really helpful and welcome. And then secondly, to endorse the plan and assure that it takes into account the priorities for Plymouth before it goes through to the NHS Devon board later in the month. So happy to take any questions on the plan.
Okay, team. Thoughts? Ruth, do you want to come in now?
Yeah, I just wanted to come in because I think when the board saw the plan in the initial state a year or so ago, there was a great deal of discussion and consultation, as John says, and I think we clearly supported the plan, and the statement that we've put in there endorsing the plan and saying that it sets out the direction of travel is still the case. I mean, you won't be at all surprised to know nothing has dramatically changed about what we would expect to see in Plymouth in the future in this 5-year plan. So I think that from my point of view, I feel assured that this plan is still valid and relevant for Plymouth as it is across the Devon system. I think there is an elephant in the room, and the elephant in the room a little bit is how much is this realistically going to be able to be delivered given the circumstances that we know that the whole system is operating in. I don't necessarily think that that has to be addressed in this discussion, because this is about the joint forward plan. This is about setting out what we want to be able to achieve and where we want to go. And clearly there's a lot of work being done across the system, and with things like the operating plan, etc., that has to be developed for the NHS, that will set out those steps towards how we're going to achieve that, along with, you know, the considerable statutory challenges that I think it's fair to say are challenges that the system needs to meet, given its not for status. So I think I just wanted to sort of draw that slight distinction between, you know, this is setting out the vision and the direction of travel. It's in line with what we would expect to see for Plymouth, and you know, to acknowledge that yes, there are going to be some challenges around some of the deliverables around that, and that is, as I understand, being worked upon sort of at the same time, to make sure that the sort of delivery of this is being planned through, along with the delivery of those other statutory targets.
Thank you very much indeed. So, views. Tony, you were in the original consultation, weren't you, last year? Your thoughts on the update?
I think from an update, you know, because it is a 5-year plan and it's moving forward, I think it, you know, the direction of travel is right, and that I guess the biggest concern is that elephant of not for, and how that will affect that plan moving forward. And I know there's a lot of work that's been done by NHS Devon around the financial situation and what that means as an operating plan moving forward for the next 12 months. So I don't think I have any major concerns over what's being produced here, but just that sort of note about the white elephant of finance.
Thank you. John, did you want to come in at all? No? Okay. You know, I think obviously from Plymouth's point of view, we will be there, I'm going to say, fighting our corner to make sure that we get the best that we can for our citizens. And I think that, to me, is what's really, from our perspective, is important. And you know, their outcomes, health outcomes, you know, that they're essential to us. Chris, did you want to come in at all on this?
Yeah, I mean, I agree with what has already been described. As Ruth said, the deliverability against the operating environment that we're currently in creates challenge. But you know, it does still reflect the ambitions as they were. We have been having a number of conversations around local care partnership and our priority setting process around that as a Plymouth system partners. And there is alignment back to that. You know, there is read across in terms of our thinking around that space. But again, recognising that in the context of the requirements that are placed on us nationally.
Thank you. Well, anybody else got any thoughts? You're getting an easy ride today. Okay, well, there's no way that I can protract this any longer, I don't think. I think we have some recommendations. They're in the paperwork, as she says, trying to find them quickly at the beginning of your pack. So on page 119, and in fact on 120, we consider that the refreshed Devon Joint Forward Plan and provide comment and feedback to the Integrated Care Board to support its ongoing development. And then secondly, we endorse the plan and assure that it takes into account the current health and wellbeing strategy for Plymouth. Are you all happy to support those two recommendations? Yep. Okay.
Through you, Chair.
Yeah.
I think, again, there's a need for a delegation there for us to go away and provide maybe some properly worded comments, summarising the discussions today back to.
Yes, I think that would be really useful. And John, when does the board meet to consider this? Do you know offhand?
So it's this month. I've forgotten what the date is, but
Yeah.
the next couple of weeks. So we'll need that quite quickly.
It's got to be done by the 1st, hasn't it? I think something. It's got to be ready for the 1st of April sort of thing. So yes, we'll do that certainly. Okay. Right. Thank you very much indeed for joining us.
Thank you. Nice to see you all.
Okay, that moves us on to item 9, which is tracking decisions. Okay.
Thank you, Chair. So members will see I've updated the tracking decision log within your packs. I can skim over them briefly. The main point I'd like to state is that before we're now going into pre-election period, over that time I will collate all of the final responses. Obviously, we won't have a meeting now until the new municipal year, and I'll circulate those round. Nothing of concern, most are on track. Some of the ones we've asked for are slightly longer pieces of work, especially a few from the ICB on collating numbers on prescriptions and things, and I'm sure Chris will chip in a minute, but we'll have them for the next meeting. So I suppose one that you particularly as well want to raise, Chair, is the update on defibrillators. That's been really positive. We've now secured match funding, or been offered match funding for defibrillators. So all of those that we recommended now are either in place or being installed. If anyone's got any questions on particular ones, I'll take them. Thank you.
Any questions? Anything from that report? Certainly as far as the vaping's concerned, we're waiting for government to come back, aren't we, Ruth, with the latest consultation. It'll be interesting. I mean, they're talking about raising the tax on vapes, aren't they, etc. But that's not till, I thought it was 26, I thought, but it may well be they've delayed it that long simply because there could be something else coming in meanwhile. I think that's watch this space, isn't it, Ruth?
Yes, I think we're awaiting updates around the legislative processes, and as you say, the detail about what would actually go through in that time.
I suppose I would just add, Chair, that work on following the agenda set for the vaping working group, we're working on coming up with all the presentations and invites, and we're looking to hold that session in the new municipal year, obviously subject to latest government policies and updates.
Thank you very much indeed for that, which brings us on to the work programme.
So I'm worried that the next meeting isn't until the 20th of the 6th, so there's quite a while between our next one. Items that are quite pertinent for consideration might be the bring back of Thrive Plymouth. Ruth, I don't know the exact deadlines on that, but I think that suited the timings. We also had a couple of items from NHS Devon that Chris said last time could be brought forward in 6 months, and that would have been 6 months. So I wonder, Chris, if the long-term plan and recovery plan could be brought.
Yeah, long-term plan, recovery plan, equally as well. The LCP priorities will have concluded that work in terms of priority setting for the new year, too. So could bring that in as well.
Okay, so I think what I'd like you all to do is to get your thinking caps on and see if there are any other items you've got there. I mean, I know we've got the Ageing Well, which is now full of life rather than Ageing Well, so it doesn't get confused with the government item on it. And also the Dental Task Force, hopefully I'm not saying I'll have anything conclusive to tell you or revolutionary to tell you, but we could have an update on that as well in that new municipal year.
Yeah, just to say, Chair, if all goes to plan, we would have had our actual meeting by then, and the plan would be to bring back the results and findings to the board for discussion at the first meeting. But obviously, we'll watch that space.
Okay, right. So we'll note the work programme and estimated finish time. It says 12:50. Well, we've beaten the clock. That's got to be a sheer record, I reckon. So can I say thank you to everybody for turning up, and thank you for your contributions over this past year. we have pulled some very good points out, and we have done our best to make sure that the Health and Wellbeing Board has been proactive. So thank you. And thanks to Chris and to Ruth and to Rob in the background there, who's shy today, but thank you to the three of you in particular for your support over the year. We do appreciate it. And we will catch up with you all soon. Thank you very much indeed. Bye.